My name is Professor Davis. I'm a paediatric endocrinologist based at the University of Southampton in the UK. And these are my co-chairs, Professor Marco Cappa from Rome in Italy and Professor Richard Ross from Sheffield in the UK. These are the faculty disclosures. And this is our international committee. We have Maria Craig from the Children's Hospital in Sydney, Australia, Maria Carolina Salerno from Naples in Italy, and Mr. Jeff Bolton from the Child Growth Foundation in the UK. Medical Education Academy is partnered with the Asia Pacific Pediatric Endocrine Society, the Child Growth Foundation, and the Italian Society for Pediatric Endocrinology and Diabetes. So these are the learning objectives of our webinar. We're going to explain the benefits of a skilled clinical assessment and the role of biochemical screening, endocrine evaluation, and genetic studies in the assessment of a child with short stature. We'll discuss the understanding of the safety and efficacy of growth hormone administered once daily in managing patients with short stature, increase our understanding of the relationship between adherence to daily growth hormone and treatment outcomes, expand clinical and psychological management techniques to improve poor medication adherence with growth hormone, and also to increase the awareness of the emerging science of long-acting growth hormone to improve the understanding of their efficacy, safety, and the potential clinical applicability. These are our speakers. We have Professor Martin Stavage from the Barts and the London School of Medicine and Dentistry at the Queen Mary University of London, Professor John Wyman from King's College in London, and Professor Cherry Deal, an associate member of the Research Centre in Montreal in Canada. I wanted to highlight for everyone that the Medical Education Academy welcomes 187 participants from 47 different countries. So this is a truly international webinar, and this represents 63% of our delegates have more than 10 years experience in pediatric endocrinology, and 37% of you have up to 10 years experience. And this is our agenda. So I'm going to hand over in a moment to Professor Savage to discuss the diagnosis of growth hormone deficiency using a balanced clinical, endocrinological, and genetic approach to the child with short stature. Professor Wyman will discuss the realities of adherence to growth hormone therapy, and Professor Deal will discuss how long-acting growth hormone compares in efficacy and safety with daily human growth hormone injections. We will follow this with a panel discussion with the questions that you have raised during the webinar, finishing with closing remarks by Professor Richard Ross to end the webinar in about 90 minutes. The webinar is accredited by the European Accreditation Council for Continuing Medical Education. The program has been certified by the CPD Certification Service. So please complete your post-event survey. This is crucial so that you will get your certificate of attendance and your CME certificate, and you'll be receiving this following the webinar. It's very important, please submit your questions during the talks as they come up. There will be no time at the end of each talk. We will answer your questions at the end in the panel discussion, and the faculty will collate all of the questions to group these at the end. So please don't keep your questions for the end, submit them as the talks proceed. There will be polling questions, and we ask you to complete this. This will be possible to do using the Zoom technology. Just please enter your answer, and then we will go through the results of the polling questions at the beginning of the panel discussion. So I'd now like to hand over to Professor Savage, who will kindly lecture us on the diagnosis of growth hormone deficiency using a balanced clinical, endocrinological, and genetic approach to investigation of short stature. Thank you, Professor Savage.
Thank you very much, Justin. So I'm now just getting my slides organized and moving forward, hopefully. Right. So I'm going to talk really about the investigation of short stature. This is the polling question. The investigation of short stature needs to, 1, consider a standard growth hormone dosage in different conditions. 2, focus on acquired short stature diagnoses. 3, pay close attention to specific diagnosis or diagnoses before labeling a patient to have idiopathic short stature. And 4, concentrate on endocrine diagnoses such as growth hormone deficiency rather than general disorders such as celiac disease or Crohn's disease. So one of these answers is correct, and we'll come back to this in the panel discussion. The learning objectives from my talk: evaluate the short stature assessment protocol with a view to applying it to patients in their clinical setting, explain the key advantages of a skilled clinical assessment, and explain the value of general biochemical screening, endocrine evaluation, and genetic studies in the assessment of a child with short stature. And the presentation will follow this general structure here: normal regulation of linear growth in children, the growth plate and the growth hormone IGF-1 axis, really just to go over very briefly the physiology of growth control, classification of growth disorders, differential diagnosis of short stature, and then take you into the consultation setting and look at clinical assessment and assessment of growth hormone secretion. So this slide shows the most important tissue in the body which regulates linear growth. And basically, that tissue is in the growth plate. The growth plate is this narrow band of cartilage between the metaphysis and the epiphysis. And this is where the chondrocyte cells, which are the cartilage cells, differentiate and then basically grow and are finally calcified for new bone formation. And this is a process which is influenced by endocrine factors from outside the skeleton, principally the growth hormone IGF-1 axis, coming and acting on the cells of the growth plate. And this leads to our classification of growth disorders. And there are basically 3 fundamental categories. The first category, primary growth disorders. And these are disorders caused by primary defects within the growth plate. This is highly complex physiology, but there are a number of genes and proteins within the growth plate which are of fundamental importance for linear growth. The secondary cause is basically influences outside the growth plate, but which impinge on the function of the growth plate. For example, endocrine signals, growth hormone, IGF-1, etc., nutrition, chronic inflammation, and fluid balance disorders. This is number 2. And then number 3 are what we call idiopathic causes of short stature, which is an unsatisfactory diagnostic group, but we have to accept that in some children we simply cannot pinpoint the precise cause of the short stature. So from this slide, you can see that the etiology of short stature is extremely broad, potentially. Developmental, environmental, genetic, autoimmune, endocrine, chromosomal, psychosocial influences, and also the fact that there could well be normal variants amongst that list of causes of short stature. So here we have to remember why we went into clinical medicine, and that is to use clinical skills. And I like to suggest that it is better to approach the child with short stature as a general pediatrician or physician and not as an endocrinologist. We have to take a broad view of this differential diagnosis. So therefore, the diagnostic approach to short stature is more an art than a science. Maybe a slightly provocative statement, but don't forget the art of clinical skills. And finally, look at the patient rather than the computer screen. So as we go on, there are three basic approaches to diagnosis of short stature. One is the clinical approach, consisting of taking the history and the physical examination. The second is the biochemical, radiological, and endocrinological approach, consisting of general pediatric tests, the radiology, such as MRI scan, and then the endocrine assessment. And then there's thirdly genetics and genetic sequencing. And I want you to consider these sort of three different approaches. So let's look at taking the history. I'm going to slow down because what I'm going to say now is of absolutely fundamental importance. Taking the history is crucial in the investigation of short stature. I know often we are time limited, but you need to take the time to basically ask using direct questions and listen to the patient's and the family's answers. This is very important. Taking the history is the time when we establish a relationship with the family, and also we observe the dynamics of the family. Now, there are certain key questions, and I'm not going to go through this list, but my point is that don't simply say, okay, so no gastrointestinal symptoms, tick, no respiratory symptoms, tick, no renal urological symptoms, tick. Because if you do that, you're doing what a computer can do. And here there is something of a conflict with artificial intelligence, because AI can get the answers to these broad questions, but it cannot ask the precise, direct questions, which will lead us closer to a diagnosis. So we need to ask direct questions. We then go on to physical examination, and here you have the structure of the diagnostic approach. And obviously, oxology is crucial. There are certain key facts which we need, such as the heights of the parents, the birth weight, the gestational age. And then we come to the second important aspect of clinical assessment, which is examination of the patient, particularly for dysmorphic features. We need to learn to become skilled observers. Now, some people say, well, every child with short stature looks the same, but that is absolutely not the case. And here you see an example of a number of children, and they all have specific phenotypic features, some of which are dysmorphic. And it's our role as clinicians to actually pick up and detect these features. For example, the child with Turner syndrome. Many children with Turner syndrome look almost normal, but you need to pick up the low hairline. The child with Noonan syndrome, you need to look at critically and pick up the fact that the eyes are widely spaced and that the ears are low. And then Silver-Russell syndrome, the so-called relative macrocephaly. The child with Cushing's, who has a moon face, often without other features of striae or virilization in young children. The patient with severe growth hormone deficiency, who has mid-facial hypoplasia. And these are just examples, but finally, the child with 3M syndrome, with that absolutely characteristic upturned nose. And it's after many years of practice that we get skilled in detecting these features. So then we go on, we've assessed the child clinically, and the question of general pediatric screening tests. Now, this is something of a controversy. Back in 2008, a number of us wrote this list on the left and suggested that these tests should be performed in children with unexplained short stature. And this is what I always did when I was practicing clinically, and I strongly recommend this. However, in 2013, Dr. Sisley from Cincinnati wrote this, I think, rather provocative article in the Journal of Pediatrics, because she identified 235 children who looked normal but were short, and she carried out this list of tests and stated that 98% of the tests were normal. So basically made the statement that general pediatric screening tests were not effective in healthy children. Well, I do not agree with this recommendation. I think all short children without a diagnosis need general pediatric tests, because otherwise, how can you tell that the patient in front of you does not have celiac disease or Crohn's disease or a mild form of Turner syndrome mosaic? You cannot do it without doing these investigations. And the time to do them is now, after the clinical assessment, before starting endocrine assessment. Now, there is something of urgency because we are making the diagnosis of growth hormone deficiency very late. And here you see some figures. In Germany, they've made very good advances, shown here. I know in some parts of Germany, there's really been an excellent advance, particularly in Leipzig, I would say. In the United Kingdom, we're still diagnosing growth hormone deficiency around the age of 7 or 8. And so there is urgency. The earlier we make the diagnosis, the earlier we give treatment, the better the long-term outlook. Let's move to endocrine assessment. It's really impossible to avoid doing a growth hormone stimulation test. I know there are some parts of the world where this has been phased out. I can't comment on that, but I think it's very important to consider doing this test. You don't have to do it in everybody, but for example, it's not required in the patient who is growing normally, has a normal bone age, and a plasma IGF-1 level above the mean, because growth hormone deficiency has essentially been discounted in this patient. But in other children who are growing slowly and are short, it is crucial to do a growth hormone stimulation test. It's not a physiological test. It's been criticized for the last 30 years, but it does give you an answer as to whether your patient has growth hormone deficiency, definitely, and that would be a peak growth hormone level of less than 7, or has normal growth hormone secretion. And that information is of fundamental importance in the management of the child. And we would take 7 micrograms per liter as the cutoff between normality and growth hormone deficiency. The other question is, should you use sex steroid priming before you do the growth hormone stimulation test? I am an advocate of this. I recommend it. Essentially, it is during puberty, it is sex steroids which are responsible for increasing growth hormone pulsatility. And therefore, what we are doing here is we are trying to differentiate between the child who has growth hormone deficiency and needs growth hormone replacement, and the child who simply has constitutional delay of growth and puberty, with delay of puberty, but ultimately normal growth hormone secretion. And we can distinguish between the two by giving sex steroids for 2 days before the test, and we use oral stilbestrol in boys and girls. And in the child with constitutional delay of growth and puberty, this will normalize growth hormone secretion. And that is extremely important. So in terms of other endocrine assessment, IGF-1 is potentially a value, but you can only interpret IGF-1 if you know the level of growth hormone. Because you see here, you have low levels of IGF-1 in growth hormone deficiency, and you have low levels in some short children with non-growth hormone deficiency. So you need to know the level of growth hormone. But IGF-1, I think, can support your diagnosis. Of course, we need to use our clinical skills if we see a child who looks classically growth hormone deficient. This phenotype is rare. We don't see many children with extreme features of growth hormone deficiency like this little boy. The features in infancy, I'm sure, are well known to you: jaundice, midfacial hyperplasia, etc. But again, let's use our clinical skills. If we see this, it is a meaningful finding. And if we do diagnose growth hormone deficiency, we need to perform a follow-up MRI scan. And as you know, the classical MRI appearances in the child with severe growth hormone deficiency are: 1, ectopic posterior pituitary, comes up as a bright spot; 2, agenesis of the pituitary stalk; and 3, anterior pituitary hypoplasia. And these children could be expected to have additional anterior pituitary deficiencies at some point as they grow older. Now, I just wanted to remind us all that basically growth hormone deficiency in children is a very broad spectrum. You have the extreme cases, as I showed you, like this little boy on the left, but this is rare. Much more common, you have the child who is short, who is falling behind in terms of physical growth, can't reach the basin or hang his coat up on the peg at school. And this is much, much commoner. So, and also, I'm not going to talk about therapy, but in terms of treatment, it is the child with the extreme deficiency who is much more responsive, as you see these height velocity values at the bottom, much more responsive than the child with moderate growth hormone deficiency. So finally, genetics. So where does genetics come? How important is genetics? Well, this is something that we need to get a handle on because people are making statements. For example, Dr. Dauber, who I know and respect very well, he's an outstanding clinical scientist, majoring in genetics. He wrote, standard medical evaluation rarely leads to a diagnosis. Should genetic testing become the first-line evaluation? Question mark. Should the diagnostic paradigm change? Question mark. So we need to be prepared to answer these questions because there are lots of papers coming out showing that there is a high diagnostic yield following population genetic studies in children with short stature. So what are the options? Well, I mentioned karyotype before. It is really a question of gene sequencing opportunities. Which are the patients in whom or from whom DNA should be taken and sent to a growth genetics laboratory? The first approach is the so-called candidate gene approach. And nowadays, we would only do this when we have almost a certain diagnosis in front of us. Much more common is the use of a so-called gene panel, where the laboratory will sequence a number of genes which have been linked with short stature to see if any gene variants come up. And then finally, at the bottom, there is whole exome sequencing. And this is really for children where the diagnosis is absolutely unclear. Now, I would recommend that genetic investigations, when are they helpful? They're helpful in a situation where you have a number of so-called red flags. When you have parental consanguinity, of course, a much higher incidence of genetic defects. Where you have a severe phenotype, but with normal stature parents, suggestive of an autosomal recessive disorder, where you have a single affected parent, for example, a skeletal dysplasia dominantly inherited. And of course, when you have a family history of affected siblings or in an extended family. Now, these are red flags. When you have a recognizable phenotype and endocrine features suggestive of a genetic syndrome, and finally, when there's a severe multisystem phenotype, but of unknown cause. So I would recommend not performing genetic sequencing in all patients, because the evidence is that the more severe the short stature, the higher the pickup. But just concentrating on these so-called red flags. So you can read really a broader version of this, my presentation today. In this paper we wrote in 2021, Balanced Assessment of Growth Disorders using Clinical, Endocrinological, and Genetic Approaches. And we need to be strong in terms of preserving clinical skills, because the number of publications coming out, shown here on PubMed, on growth genetics is enormous, because of course the technology is here now. And one paper, for example, in 2021, clinical profiles and genetic spectra of 814 Chinese children with short stature, came up with a conclusion that pathogenic or likely pathogenic variants were present in 111 genes. Now, these sort of studies are not really designed to help us make a diagnosis of short stature. So we have to respect this scientific data, but see how relevant it is to our clinical assessment. In conclusion, clinical assessment of short stature should have equal status with endocrinological, stroke radiological, and genetic investigations in the hierarchy of evaluation. Clinical assessment is essential to establish the patient-physician relationship and to show commitment to care, particularly when we're taking the history. The key components are look, ask, and listen. Look at the patient rather than the computer screen. Following this model, clinical assessment can provide diagnostic clues in the majority of cases of short stature. Biochemical screening, in my view, for general pediatric disorders is essential, and genetic studies for pathogenesis of growth hormone deficiency should be performed in specific situations, the so-called red flags, such as consanguinity, severe phenotype, and severe unknown syndromes. Thank you very much for your attention.
Thank you very much, Martin, for a wonderful and very, very clear presentation. And I just remind participants to ask their questions during the presentations, so these can be answered in the panel discussion. And now I'd like to introduce Professor John Whyman, who is Professor of Psychology as Applied to Medicines at King's College London, UK, and he's going to talk on the realities of adherence to human growth hormone therapy. John.
Great. Thank you, Richard, and hello, everybody. Here is the polling question that relates to my talk. So what I'd like you to do is just to listen to these 4 statements and identify with your polling response which one you think is the correct one. So if we consider clinicians' neglect of poor adherence to growth hormone therapy, what can this result in? Is it 1, prescription of insufficient dosage of growth hormone? 2, inability to define the causes of poor response to growth hormone? 3, the patient receiving a greater growth response to adult height? Or 4, the overuse of e-health devices to improve growth? So do choose the one which you think is the accurate statement. Thank you. The learning objectives of my talk today are two really. One is to really understand the different causes and components of treatment non-adherence. And secondly, to be aware of clinical and psychological management techniques to improve medication adherence with growth hormone treatment. So we start just by considering adherence. I think we all know that when we're talking about adherence, we're talking about the extent to which the patient follows the recommended treatment. And I think it's important to realize at the outset, it's not a single thing. There are three quite distinct phases of adherence to treatment. And we refer to these as uptake, implementation, and persistence or discontinuation. So by uptake, what we're really referring to is whether the patient actually starts the treatment. This can take two forms. They may be prescribed a treatment and either fail to take it to a pharmacy, or they may obtain the treatment but never really start. And we often refer to this as primary non-adherence. And we'll come back to that in a moment. Implementation really refers to the way in which the treatment is implemented or embedded in the daily routine in a regular way, in an ordered way, so that treatment is taken in an organized way and consistent way. And then the last phase really refers to the extent to which the patient, parent, stays with the treatment, how long they persist with it, and if they can discontinue. So if we sort of look at the background to understanding non-adherence in the broader medical setting, probably many of you will be familiar with the WHO report, which is now 20 years old, still a very important report, estimating that over all long-term medical conditions, somewhere between 30 and 50% of medicines are not taken as directed. So huge levels of non-adherence. And more recently, 5 years ago, the OECD produced a really important working paper around the same topic and looked at some of the economics, showing that poor adherence contributes to a large number of premature deaths every year. And the cost, for example, in Europe, just of non-adherence in terms of more complex treatments and hospitalizations and so on, is reckoned to be well over 100 billion euros in Europe alone. And if we think about those three stages, what we see is that somewhere between 4 and 31% of people never really start their treatment. They never really uptake treatment. And the figure on that, there's a sort of broad figure, I've looked at this quite a lot in my own work, around 15 to 20% of patients don't really ever start the treatment they're prescribed. Of those who do start the treatment, only somewhere between 50 and 70% of those take the treatment regularly. And then if you look 2 years later, less are still taking treatment regularly. So we can see it's a huge problem. If we think about the specific aspects of this problem in growth hormone treatment, again, quite a range of levels of adherence have been found in studies. Example, there's a range, some studies have found levels of adherence as low as 18%, whereas others have found levels of adherence up in the 90s, so quite a big range. I think probably a good way of looking at this is from national surveys. For example, there's a very good national survey from Cutfield and colleagues showing 66% of their patients on growth hormone treatment, i.e. those who were suboptimal in their use of treatment. And they define that as taking less than 85% of the treatment. I think what is very clear from all the research, and there are quite a lot of adherence studies now, is that there's a very clear relationship between non-adherence and reduced linear growth. And if we try to understand this, what we begin to see is there are a range of factors involved. And this really begs the question, sort of why? We'll come to look at that in a moment. I think the other really good study, which has been done quite recently, it was published last year, was a study looking at 4 different patient cohorts. It's an American study looking at cohorts where they collected data at 3, 12, 24, and 36 months, having been prescribed, after being prescribed treatment. And again, they defined suboptimal adherence as having a medicines possession ratio of less than 80%, and they identified discontinuation as a gap of more than 60 days after obtaining treatment. And in this very large cohort, what they found that at month in the cohort at 12, 24, and 36 months, the levels of suboptimal treatment actually increased over time from 40% at 12 months right up to 54% at 36 months. So this tells us something really important, that non-adherence is not a fixed thing, that actually it can get worse over time. So why? Why is that's the big question. Why is this happening? Well, I think we can look at two things. We can look at some of the different drivers of patient and or parent behavior, but also we can look at healthcare professional behavior and how that can impact on levels of subsequent adherence. So going back in time, the early research on non-adherence tended to identify a number of rather specific factors as causing non-adherence. They really focused very much on the fact that non-adherence would be the result of poor communication. So with the patient, perhaps not really understanding what they had to do, and how that poor communication might have quite major effects on what the patient understood and also on their ability to remember what they had to do. And a lot of the early research really thought that was it. That was what non-adherence was about. And those early interventions were based very much on things like giving people more information, sending people reminders, and these are still very much used. So that early view of things still can persist today. But I think what we see from a lot of current research is that providing people with more information or reminders to take their medicine only has a minimal effect in people who've become non-adherent. They may be helpful in people who are motivated, starting, but in people who've already become non-adherent, their efficacy is really very minimal. So more recently, I think we've started to look in more detail at the nature of non-adherence. And I think there's a really important distinction to be made between what we call unintentional and intentional non-adherence. In other words, whether the person, is deliberately decided to not take their medicines for one reason or another, which we'll look at in a moment, or whether it's unintentional, or perhaps there's some barrier. The barrier could be they don't quite understand what they have to do, or the barrier may be financial or situational. It may be difficult for them to obtain the medicine. So that distinction is an important one. And obviously what we tend to focus on now, because it's a much more challenging problem, is this intentional non-adherence, because the vast majority of non-adherence is actually intentional. We recognize, as I've talked about earlier, that there are these three distinct phases, and different factors can explain why people become non-adherent during these different phases. And now there are a huge number of studies in the adherence research literature showing that there are a very, very large number of factors that can actually affect and determine whether people start treatment, whether they stay with it, and whether they get it organized within their lives. There are so many, it would take me probably the next 3 hours to talk about them. However, there is a very neat, I think, and useful way to classify the different factors. There are three broad reasons for non-adherence, and these come from a framework called the COM-B framework. And that the COM-B framework really describes the different broad reasons. So we talk about capability, opportunity, and motivation, impacting, and B in this case is the behavior of non-adherence. And by capability, we're really thinking about a lot of those factors that we looked at in the past, things like people's ability to understand and remember what they had to do and to plan to take treatment. But also it could include physical capability, and such as one's ability to use a syringe correctly or an inhaler correctly or whatever. So there are physical capability factors. Under motivation, what we're really thinking about is the extent to which the person really wants to take the treatment, how much they are motivated to take the treatment. And that can work at a number of levels. Some of the primary factors that influence motivation are people's beliefs, but also people's moods can impact their motivation, and also can some really quite hidden factors, such as their level of habit, the extent to which environmental cues can just trigger their motivation in some less conscious way. And then under opportunity, there are a whole range of factors outside the individual patient that can impact on whether they are able to take the treatment. For example, cost of medicines, access to healthcare, the support they get from their healthcare provider, and indeed the support they get from their family or those close to them. So there are this quite wide range of factors that can impact non-adherence. And I mentioned beliefs, and beliefs are a really important factor which can influence the motivational component of non-adherence. And there are three sort of, I think, really important beliefs here that can affect the behavior of the patient or indeed the parent. There are the beliefs they have about the condition itself, for example, about, let's say, growth hormone problems, what they think has caused it, how long they think it's going to last, how much control they think they have over it, and how important it is, the sort of consequences of that condition. So those beliefs can really affect their attitude to the treatment, their willingness to take treatment. Similarly, people also have beliefs about the treatment itself. How necessary do they see the treatment? How worried are they about having to take this treatment? Worries about things like side effects, long-term effects, and so on. And also there are beliefs they have about themselves, their own ability to manage a treatment, a daily treatment, their confidence in their ability to, for example, use an injector, to make best use of an injectable treatment. So these beliefs are important, but the whole range of factors is really important in understanding non-adherence. So if we look at the patient studies, I think we learn a number of important things. Firstly, there are lots of factors that can influence adherence. Important to realize that. They can broadly be classified within this capability, opportunity, motivation framework. But also there are very large variations in the causes of non-adherence, both between patients, i.e., what impacts on one patient may not be important for another, but also within the same patient over time, those factors can vary. And that's why it's so important to identify the reasons for each patient and to tailor the support and the interventions to them and to their particular barriers and issues. So the second group of factors I want to briefly consider are those due to the healthcare professional and their own behavior. And to sort of broadly summarize quite a lot of literature, we often know that clinicians often actually don't routinely check adherence. For example, when treatment's not working, when the patient comes back following, let's say, the first line of treatment, they seem not to have changed. Let's say growth has not been impacted. So it's not a routine thing that all clinicians do, but if and when adherence is checked, then often the question is asked in a way which results in what I would call a sort of false patient response. Often people ask in a very direct way, are you taking your medicines, in that sort of way? And we know from a number of studies that makes patients very defensive. They feel they're going to be judged, and they're actually quite likely to say, yeah, no, it's fine, everything's okay, when it may not be. We also know that if clinicians are asked to just look at their patients they're treating and say who out of those patients is adherent and who isn't, they're actually no better than chance. Adherence is a sort of hidden phenomenon. They tend to be rather optimistic about their own patients. They tend to think their own patients are more adherent than those seen by their colleagues. And there tends to be what I would call a lack of ownership. In other words, they don't necessarily see it as their problem. It's somebody else's problem. it's for the pharmacist, or it's for, you know, the clinic nurse or whatever. So that again, I think is a really important issue. So what do we learn from these studies of healthcare providers? Well, we know we need to increase the awareness of just how prevalent and how impactful non-adherence to medicines and other advice can be. We also know that we need to use very different, what I would call more patient-friendly and more collaborative ways of asking about adherence in consultations. And we also know that people need to be able to identify the different reasons for each patient and tailor the appropriate support and advice and interventions to the different reasons and the different barriers that individual patients and parents may have. And that takes time. It takes training, and there are tools that one can use for that. So just in the last part of the talk, I just want to think briefly about how we can improve adherence, both in everyday consultations and also going beyond the consultation. There are a range of opportunities now for supporting and improving adherence. So in the consultation, I think I'd just like to perhaps, you know, in a way following what Martin's just been talking about in terms of what one perhaps could and should do routinely. I think what one crucially needs to do when starting treatment is to provide a really clear rationale for why this treatment is necessary. Because we know from studies of patients' beliefs that quite a lot of patients don't see a treatment as necessary, and that can be a major factor in influencing the willingness to take treatment. Secondly, I think we need to see whether patients, parents have concerns about this treatment, and to elicit those. Often those concerns may be quite misplaced, or they may be issues they've picked up somewhere else that one can reassure them about. So getting the patient or the parent into a state where they can see the need for treatment and to allay concerns they may have from the very beginning, and indeed on the way, is fundamental. If those are in place, those factors are in place, I think one needs to agree some sort of practical plan of how, where, and when the treatment is going to be taken to get into that sort of implementation phase so that you have a routine that gets set. Because the key in the long run to all adherence really is to get an established habit going or a pattern going. And then to think about whether there are any other barriers the patient may have that we haven't really thought about at that stage. Going beyond the consultation, there is quite a lot of other things one can do, and there are a number of successful approaches in a whole range of medical conditions, and they involve things like text messaging, sadly not reminder text messaging, which seems to be relatively ineffective, but messaging with particular messages around perhaps people's different barriers or helping them misconceptions and so on, much more useful. And again, tailoring those to the individual. There are quite a number of pretty sophisticated interactive programs which are really which are web-based, based on the internet, which patients interact with and can be supported on a daily basis. Phone-based support is still quite common, that's used. And there are, as I said, sort of a whole range of apps now and digital approaches which are coming into play, and more every day. Most of the apps are pretty unsuccessful. They're abandoned pretty quickly, but some of the more sophisticated ones which engage patients and look at their particular challenges and issues seem to be much more fruitful. A couple of years ago, we looked at the interventions which had been done specifically in the area of improving adherence to growth hormone treatment, and we found 15 studies then. And there are essentially two broad categories. One really involving new injection devices. The majority of studies were evaluating those, but also there were a couple of studies in which giving patients choice of treatment was the main source of the intervention. And those studies are okay. They're not great studies. And actually, what's very disappointing about them is that they were very much non-tailored studies. They didn't really look at any of the evidence which is about the factors which cause non-adherence, and they weren't really developed to challenge or deal with the different barriers. So they weren't really based on understanding of why non-adherence occurred in the first place, and the theories around that. The actual reporting in the studies of the effect sizes was really limited, quite poor, and this meant that, you know, it was very difficult to do any sort of meta-analysis or estimate the effectiveness of those interventions in any meaningful way. So rather disappointing. So where do we go? Well, the future, I mean, I think does look very exciting. There are increasing numbers of digital interventions using connected devices now, so that one can get very direct indications of when the treatment is taken. And increasingly, machine learning and artificial intelligence is being used to process a lot of the data at an individual level and to feed back and try and develop support strategies. But that's very much in an early stage. What is more common now are some hybrid systems which use digital approaches, which patients are monitored on a daily basis, but where information is fed back to the healthcare provider. And so there can be a sort of support based on the digital monitoring. I think what we do need critically are much more sophisticated interventions, and ones which are based on a proper understanding of, for each individual, about what's driving their non-adherence, and to use that to apply much more personalized, much more effective behavior change techniques to target individual barriers. So that's the future, but for the present, the take-home messages I have for you from my talk today are that one should routinely ask about possible adherence challenges, but do so in a patient-friendly way, in a way that doesn't make the patient feel defensive. Try to identify the individual barriers for each patient. You know, what's going wrong? How much is it intentional? How much is it unintentional? To what extent is it an issue around capability or opportunity or motivation? Tailor your support to addressing those barriers if you can identify them with appropriate behavior change techniques. And follow up over time to check whether that support has worked, or indeed whether perhaps other barriers have emerged. And where possible, use the digital support that's around for monitoring and managing adherence. And I think crucially, involve the whole team. So thank you very much for listening to me today.
Okay. Before to go on, I would like to thank Professor Wiseman for the complete, clear lecture. And I remind to the audience to make a question for our lecture. Now, it is a great pleasure to introduce Professor Cheryl Dill. She is well known worldwide for an outstanding production on data on growth disorder. And she will give a lecture on how long-acting GH compared in efficacy and safety with the daily eye injection. Please. Cheryl?
I'm here. I'm just waiting to control the screen.
Ah, okay, okay.
There we go. Thank you very much, and I'm delighted to be here today to speak to you about long-acting growth hormone. I will just back up and show you my disclosures because I think it's important to note that I have worked with many of the companies that have developed these long-acting products, but these slides are my own, and the opinions that I am expressing herein do represent my understanding of the current status of long-acting growth hormone preparations. The polling question for you today, it's going quickly. The polling question today: the use of long-acting growth hormone for pediatric growth hormone deficiency will lead to more prescriptions of daily growth hormone, an overall increase in the amount of growth hormone prescribed, increased treatment of allergies due to antibody generation, or a realistic opportunity for improved adherence to growth hormone. So my learning objectives today are first to recognize the various molecular modifications that have been made to the growth hormone molecule, which have permitted the development of long-acting growth hormone analogs. I want to review the efficacy of the 3 long-acting growth hormone preparations given once weekly compared to daily growth hormone injections in pediatric growth hormone deficiency that we are exposed to both in Europe and in North and South America. I'm going to discuss the current safety profiles of the long-acting growth hormone analogs, focusing on, as I said, 3 that have had approval by the EMA and the FDA and Health Canada and elsewhere. And I'm going to explain the potential long-term safety concerns of the long-acting growth hormone analogs. So let's start by talking about the recombinant human growth hormone journey, which started when C.H. Lee actually isolated human growth hormone from human pituitaries. And rapidly, it was demonstrated by Rabin and colleagues that we could use pituitary growth hormone to treat growth hormone deficient children. And this continued intermittently because sometimes it was hard to get enough cadavers to purify the growth hormone, up until the Creutzfeldt-Jakob disease crisis. Many countries did have cases from the pituitary growth hormone preparations. Thankfully, Canada did not, because Henry Friesen, our main developer of the purification process, did a slightly different purification methodology. Approval of recombinant human growth hormone then was rapidly brought to the fore in 1985. It had been in the works. And then between 1985 all the way up to 2007, we had various companies looking at other diagnoses that might benefit from growth hormone, as well as the establishment of several registries. I don't have all of them listed here, but these are some of the main ones that really helped us ask the question of safety. And that's allowed me, with these 38 years of experience, to put the flag on top of the mountain and to tell you that the trials show that not only was growth hormone daily safe and effective, but it was also safe and effective, but it was also good in real life. The efficiency, yes, you can demonstrate that in a clinical trial, but to show effectiveness, that has to be in a real world setting. But where are we now with the long-acting growth hormone products? Well, let me tell you why we developed them. You heard about how hard adherence is. Improving adherence, well, if adherence is our Achilles tendon and the treatment burden is so enormous, yes, that triad of factors that Dr. Wiseman just talked about, capability, motivation, opportunity, we can improve through better communication to our caregivers and patients. We can address their fears. We can address their concerns. We can give them psychosocial support. But mainly what we have to look at as well is to reduce the injection issues. And that's been done in a variety of ways. But one of the ways is to think about less injections. And it's also felt that if you're considering psychosocial issues of 2 working parents and sometimes reconstituted families and sometimes children that go between 2 different houses, less injections is going to be a bit easier. I don't think that's something that is a conclusion that is false, even if we don't have yet all the good data to show it. And so, of course, long-acting growth hormone is now where we're going, and it's not unique to growth hormone. As you know, we've got long-acting products in hematology, in immunology, in diabetes, in many, many different therapeutic areas, because the reasoning is always the same. Let's make it easier for our patients. So we have another mountain to climb, and I don't have the flag on the top of the mountain. I'll tell you why, mainly because we don't have quite the length of time to really look at real-world effectiveness and safety. I show on the left in different colors all the molecular approaches that have been taken to develop these long-acting growth hormone preparations, from depot injections, which were actually the first approach used by Genentech at the bottom of the mountain, for Neutropin Depot, which was approved in '99 and marketed, but then withdrawn for a variety of issues I don't have time to go into today. We also have pegylated formulations, fusion proteins, prodrugs now, and albumin binding moieties that are added. But you can see with those red X's, many of these various approaches have not led to regulatory approval. And the regulatory approval that I show here is really for 5 main products. The 2 at the bottom, the Gene Science and the LG Life Science products, they have been approved and are marketed in Korea and in China, and I won't discuss them today. Note that one is a depot injection form and one is a pegylated form. Those that have been approved by the EMA and FDA in many cases are the Pfizer drug somatrogon. Novo Nordisk's somapacitan has been approved in adult growth hormone deficiency, and pediatric growth hormone deficiency is pending in many places. Ascendis, the Lonapeg somatropin drug, is also now approved by FDA and EMA. And notice, all those 5 drugs have all used different molecular approaches. So we have a wonderful opportunity in the next 30 or so years to really let these drugs go up head to head and see what comes out. So let's talk about the big 3. Let's talk first about somatrogon, which is a human recombinant growth hormone linked to 3 copies of the C-terminal peptide of human chorionic gonadotropin, which, as you know, is a glycoprotein. And it's this CTP unique to the glycoprotein hormones that is responsible for the longer half-life of HCG. The CTP actually extends the half-life by decreasing renal clearance. And this is not the first time the CTP has been added to a hormone. The same technology has been used for CTP FSH, which has been marketed and used in my center and fertility clinic for over 10 years for ovulation induction. It's given by once-weekly subcutaneous injections. There are 2 multi-dose pre-filled pens, and regulatory approval for pediatric growth hormone deficiency has been given by the EMA and in Canada, Japan, Australia, Brazil, Switzerland, Taiwan, UK, United Arab Emirates. I'll be going over to South Korea shortly to discuss their very pending regulatory approval. I think it's going to have a very wide take-up. But so will somapacitan. And somapacitan is a different approach. The schematic is shown here on the right. So you have the growth hormone molecule, and there is a hydrophilic linker which permits the molecule's binding to albumin through a fatty acid moiety. And it did require an amino acid substitution in a non-growth hormone receptor binding amino acid of growth hormone. But the binding to albumin is non-covalent, it's reversible. And this thus reduces clearance and significantly prolongs the in vivo half-life. This has been a previously used method for the development of long-acting insulin, and the miracle drug liraglutide, which, as you know, is a GLP-1 analog. So we have precedence. And once weekly subcutaneous administration is given by, again, a multi-dose pre-filled pen, which now comes in 2 sizes. And it was first approved for adult growth hormone deficiency by the EMA in Japan, and the pediatric growth hormone deficiency approval is pending. It should be very, very soon. It has about the same half-life as somatrogon. And our last of the big 3 is lonapeg-somatropin, or TransCon, which is an inactive prodrug with a half-life that's shown to be about 25 hours. So they're all in around the same range of half-lives, and that's why they're all given once weekly. And here what they've done is they've transiently bound their recombinant human growth hormone to methoxypolyethylene glycol, a long chain of these PEG molecules, via a proprietary linker. And this linker is interesting because once the large molecule of 63 kilodaltons gets into the human body, into the subcutaneous space, over time that linker is cleaved in a very pH and temperature dependent manner. And once it's cleaved, that allows the human growth hormone to dissociate from the methylpolyethylene glycol molecule, which had effectively minimized renal excretion receptor binding, but it itself is eliminated by renal excretion. It's once weekly subcutaneous injections. We don't have any comparator drugs with the same technology, but I will say that both TransCon PTH and TransCon CNP, the C-type natriuretic peptide, are in phase 2 and 3 trials. So they are going to be using this technology for other drugs, but we just haven't seen it yet. There are single dose cartridge injection devices. So what this means is there is a fixed weight range that you can use an individual cartridge in. And regulatory approval has been given for pediatric growth hormone deficiency by both the FDA and the EMA. So let's have a brief overview of these 3 drugs in their phase 3 pivotal trials. The inclusion criteria are like for our original growth hormone deficient children. You had to be treatment naive, and depending on which drug we're talking about, you couldn't be any younger than 2.5 or 3 years, and you could not be older than 10 years in girls or 11 years in boys. The maximum stimulated growth hormone had to be less than or equal to 10 nanograms per mil, 10 micrograms per liter, which is actually a rather high level for peak stimulated growth hormone if you're talking about a 3rd generation assay. The height SDS had to be less than or equal to -2 SDSs, or a height velocity less than 0.7 SDS, which is a 25th percentile. And they had to have an IGF-1 score less than or equal to -1. And some of them had a BMI criteria as well. They could not have a BMI less than or equal to -2 SDS. So they wanted relatively well-nourished. They could be lean, but they had to be well-nourished. They had to be prepubertal. And the comparative drug for all 3 trials was daily somatropin at the same dose, 0.24 milligrams per kilo per week. Duration of the phase 3 trial, 52 weeks. And then patients were offered the possibility of switching to the long-acting preparation for the open label extension trials, which are ongoing. Of course, tumor patients were excluded. There were no identifiable syndrome patients, such as Turner syndrome. The rest of the exclusion criteria were very similar to the previous daily growth hormone trials in growth hormone deficient children. I will say that the multiple pituitary deficit patients were included, but they had to be on stable hormone replacement doses. This is a brief overview now of the primary endpoint for all 3 of the trials, which was the estimated treatment difference in height velocity given in centimeters over that 52-week period, centimeters per year, with their 95% confidence intervals. These were non-inferiority trials. The red line expresses where the margin of inferiority lay, which was minus 1.8 centimeters per year for all of them, as was discussed by regulatory before the trials commenced. And you can see that they all hover around the 0, but they're well to the right of the margin of inferiority. So they all succeeded in getting regulatory approval based on this, and as we'll see, the safety profiles. The efficacy conclusion for the 3 products was quite similar then, that there was a similar efficacy to daily recombinant human growth hormone with non-inferiority achieved for both somapacitan and somatrogon, and statistical superiority with Lonapeg somatropin, but we're not yet sure of the clinical relevance, and we have to follow this over time. The other endpoints included mean height velocity and height velocity SDS, and those were increased in all of the trials. The increase in height was sustained up to 5 years, and these studies are ongoing, and I'll briefly show you a mention of what we're looking at for the open label extension data. We have some data to near final height, which suggests that yes, it's achieved, and it may be even a little bit better than the genetic target height. Bone age advancement was proportional to the change in chronologic age, similar to what we see with our daily growth hormone. The mean change in IGF-1 SDS was also similar in the long-acting growth hormones and was comparable to daily growth hormone. We're going to talk a bit more about this in terms of use of IGF-1 as a safety parameter. And the adult studies with somapacitan did show reduced truncal fat percentage. So there was clearly an improvement in the adults of reduced visceral fat, improved lean body mass, and IGF-1 SDS, but we don't have comparable body composition data for the pediatric long-acting growth hormone trials. So safety. This is, as clinicians, our primary concern. And I do feel that overall, the 3 products are well tolerated. The adverse event profiles are quite similar and comparable to daily recombinant human growth hormone. Site reactions have been reported in the trials with quite a bit of variability. And variability not only between the drug that is being tested, but also even in the comparator arm. And that's probably dependent on how the pain data was collected. Were there questionnaires administered carefully at each visit to both parent or caregiver and to the child? How did the clinician weigh in? How was it reported in the daily visit report forms? In any event, when pain was graded, it was rated as mild to moderate with decreases over time. There were very few serious adverse events and not believed to be linked to the drug under study. And the most frequent treatment emergent adverse events are shown here and were found also in the comparative to the same or slightly lesser extent. As in the daily recombinant human growth hormone subjects, anti-drug antibodies were detected, mostly to the human growth hormone molecule, and reported titers were highly variable over time. And neutralizing antibodies that actually interfered with growth were not found except in one patient where you might expect to find it. That was a patient in the Lonapeg somatropin trial that had a growth hormone 1 gene deletion, never seen any growth hormone. There were no concerning metabolic signals relative to the daily growth hormone, and the delta BMI was quite variable, but again, we didn't know whether this is due to delta lean or delta fat mass. We have to have those trials. Let's talk about dose considerations and safety monitoring. First of all, these long-acting preparations are never indicated for the newborn or young infant to control hypoglycemia in the context of growth hormone deficiency. We need the more rapid metabolic effects with daily growth hormone. And that was recognized by all three companies because approval for somatostatin is only as of 2.5 years of age. And for somatrogon and Lonapeg somatropin, it's only as of 3 years of age. Don't try to make dose comparisons between the long-acting growth preparations or between long-acting growth hormone and daily growth hormone. The molecular sizes differ. Even more importantly, the PK/PD differs. So the pharmacokinetics, including the serum levels of the drugs and the elimination routes and rates, differ. And the pharmacodynamics may differ in a very tissue-dependent manner, which we haven't yet explored in the human. All we use as a surrogate PD marker is circulating IGF-1. And the current consensus guidelines for daily growth hormone suggest maintaining IGF-1 within 0 to +2 SDS. And it is felt that these guidelines should apply to the long-acting growth hormone preparations. But again, we don't really have any long-term data, safety data. This is just intuitively knowing that we don't want to go above and beyond physiologic conditions when we're replacing a hormone that's missing. Now, given the delayed rise, so the peaks for the 3 are about to day 2, and the gradual fall over the week of the IGF-1 levels, timing of IGF-1 evaluation is problematic. And different approaches have been used, including modeling, PK/PD modeling, to calculate an estimation of mean IGF-1 during the week, and then to determine which sampling day approximates the mean levels. But I will say that electronic algorithms are not yet available. They're under preparation and they will be useful. So I show here the different phase 3 pivotal trials for the 3 drugs. The first horizontal line is for the dose that you give it at. And I put in red, please use ideal body weight in obese children. There is an article that is in press in Hormone Research Pediatrics. Andrew Dauber reported an obese child that was given the dose as per his actual weight, and he developed symptoms and an IGF-1 level that really shot up high. The IGF-1 SDS at 52 weeks was given in the 3 trials, but in very different formats. And so I think they're all valid formats. Comparing them between each other is a little bit difficult. You can see the somatrogon gave a mean measured SDS on day 4, as well as the somatostatin. It was a mean measured between day 4 and 6 after the injection. And the Lonapeg somatropin gave a least squares means of an estimated IGF-1 over the week. And the daily comparator in the growth hormone, daily growth hormone molecule, was hovering around a mean SDS for IGF of 0. Now, there are open label extension trials. There is good retention for them. We have no new safety signals. We have 3 of them that are published, and I put them there just to show you how many years out we are from the various trials. The open label extension for the phase 3 somatrogon is 4 years now, 8 years of the phase 2. Somapacitin, a year past the phase 3 REAL 4 trial, 5 years past their REAL 3 phase 2 trial. Lonapeg somatropin, again, you see how far out they are. We don't have all that published data. We only have the publications I show you above. And when you go on the wonderfully useful site, clinicaltrials.gov, you can see what other trials are being planned by the companies. Somatrogon, Pfizer has not posted any new trials. Somapacitan is recruiting for a basket study for SGA, Turner, idiopathic short stature, and Noonan. They also just published a SGA dose finding study, which is now moving into the ongoing open label extension phase. And lonapeg-somatropin is recruiting for Turner syndrome and adult growth hormone deficiency. So we're going to be seeing a lot of data in the near future. I'm going to briefly tell you about patient and caregiver reported outcomes and the treatment burden and adherence. We have very little data. There was a crossover study of 12 weeks with 85 patients done with somatrogon, and they used a whole series of questionnaires to look at both patient and caregiver judging of treatment burden and adherence, and basically it was very positive. Somapacitan had a much fewer number in their OLE of the phase 2, but they did show in a certain number of respondents, so the majority tested, that they also answered they'd be more adherent to somapacitan rather than to the daily recombinant growth hormone. And the lonapeg-somatropin didn't do any treatment burden per se or adherence issues, except to compare using a syringe and needle versus their auto-injector, the fixed dose auto-injector. And it seems that there were less local reactions of pain, tolerability with the device. So I'm going to finish up with the unknowns relatively quickly. I think you probably have them all in your head. You've seen them, you've heard about them. We don't know how these preps will interact with the growth hormone binding protein. Will the full prodrug interact with the growth hormone binding protein or just the cleaved growth hormone? Do modified recombinant human growth hormone molecules penetrate all tissues with equal efficiency? And what are the long-term effects on all the organs? What about renal elimination and accumulation of the carrier molecules? Cardiac function, the degree of tonsillar and adenoid hypertrophy and obstructive sleep apnea, is that going to be just related to IGF-1 levels? What about scoliosis, liver function, lipid profiles? Does the binding of the modified growth hormone molecules to the growth hormone receptor ensure the full growth hormone signal transduction, not just of the growth signals, but also the metabolic signals? And is long-term neoplasia risk the same as for daily growth hormone? Furthermore, how often and when should we measure IGF-1? Should they be done at certain times post-injection? Would this mean more clinic visits for patients and difficulty coordinated blood drawing? How accurate are the PK/PD models to predict the mean weekly IGF-1 levels, regardless of the time of sampling? And will serum IGF-1 levels be useful for dose titration? How will puberty affect dose requirements? We know that in the normal individual, the growth hormone sufficient individual, growth hormone increases quite significantly during puberty. We need registries. This is a plea. They're being developed by all three of the companies, and we also have Faisal Ahmed leading the GlobeReg registry from Glasgow. The HTTPS is there, and I urge you to consult it while we're waiting to get everybody enrolled in the company follow-up. We can also do our bit and enter patients in that. It's very easy to do. My take-home messages, and this is my last slide. I think these products are a long-awaited innovation, and I think they should help with patient and caregiver adherence and ease some of the burden of growth hormone therapy. I believe the efficacy is comparable for the three products. I think the treatment monitoring using previously determined sampling times, it is feasible, but we need to have easy-to-use electronic algorithms, and these have to go through regulatory approval, in case you didn't realize that. The short-term safety profiles seem to be good and comparable to daily growth hormone with no new concerning safety signals. The long-term monitoring is required to address the real-world effectiveness, the absence of neutralizing antibodies, metabolic outcomes, and long-term neoplasia risk. And currently, I stress there are no other indications for using long-acting growth hormone in pediatric patients. but we have a lot of ongoing studies, so hopefully we may be able to bring this innovative treatment to other patients that are currently on daily growth hormone. Thank you very much, and we all hope to have your questions.
Well, thank you very much, Professor Deal, and thank you very much to all of our speakers. We've very much enjoyed your talk. So I think before we move into the panel discussion, if we could just have the results of the polling questions, if those could be displayed. Okay, so this was the investigation of short stature needs to, and the majority of people answered correctly with pay close attention to specific diagnosis before labeling a patient to have idiopathic short stature. Thank you very much. And the next question. And this was neglect of poor adherence to growth hormone therapy can result in, and the majority of people answered correctly, with the inability to define the causes of poor response to growth hormone. And the next one, please. Right, so, the neglect. Is that the last one? So use of long-acting growth hormone for pediatric growth hormone deficiency will lead to a realistic opportunity for improved adherence to hormone. That's great. Thanks very much. And that was the correct one too. Okay, so if we could, so thank you very much for the audience or the delegates for contributing some questions. I'd like to start off with a question for you, Professor Savage, which came through, which was, so do children who fit the criteria for being given growth hormone for short stature being born small for gestational age, but also have a known genetic condition which can cause SGA and short stature, should growth hormone be offered to those children?
Okay, that's quite a difficult question, because I suspect we're dealing with various rare conditions associated with being small for gestational age. I mean, some conditions being small for gestational age, for example, are not related to growth hormone insufficiency. They're actually related to growth hormone resistance. So I think you have to be careful. You have to look at the evidence for growth hormone deficiency. And if it is there, then by all means, prescribe growth hormone, but with one caveat, to make sure they don't have, for example, something like Bloom syndrome, which is associated with being small for gestational age and having an increased risk of malignancy when growth hormone is prescribed. I think it's a question of looking very carefully at the individual condition and the relative safety in the literature and efficacy related to growth hormone treatment in that condition.
Okay, thank you very much. May I ask you another question? So what do you think the positioning of genetic investigation should be? I know it'll depend on availability, but for children who will be commenced on growth hormone for short stature secondary to being small for gestational age. And the reason I'm asking that question is that those results, as you know, that the results may influence, and you just mentioned one reason, chromosome fragility problems, which would be a contraindication, but it may also influence the dose of growth hormone you give in rasopathy or in shocks. Do you think that there will be a case for using these gene panels, for example, routinely, even though the pickup rate for those conditions may be low, prior to commencing growth hormone therapy?
Yes, I mean, I think if you have a condition, you mentioned rasopathy and Noonan syndrome, where there is an identifiable phenotype, I think that is an indication to do genetic studies to basically clarify if there is a mutation present. And of course, you take something like Noonan syndrome, And there is a differential response to growth hormone depending on the type of mutation that is identified in Noonan syndrome. So I think the more genetic information that comes in related to specific phenotypes, the more there will be an indication for genetic studies. But let me just make one point, and that is, if you're going to do genetic studies, try to build a relationship with the scientist actually performing the studies, because in that way you get much more information back, and that will be useful in terms of the management of the patient.
Okay, thank you very much. I'm just going to ask my co-chairs whether they have any further questions.
I have a question for John Wyman, if that's okay, Justin. So John, you don't mention in your talk on adherence once daily, once weekly, once monthly, once yearly, thrice daily, fasting or not. Is that because you don't, and they may be a convenience for people, but do you see them not as being really key to adherence?
They are important, Richard. It's an important question. In my crude three-way analysis of the factors influencing non-adherence, they would be in that opportunity. They're sort of factors outside the patient. So things like the difficulty of taking treatment, the frequency of treatment, treatment burden, all those things clearly have an effect. We know from quite a lot of studies that the less frequently you have to take the treatment, let's say during a day or during a week, the greater chance there is of improving adherence. So there clearly is a relationship there, but it's not particularly strong. You know, some of the motivational factors are much stronger. You know, if someone really is worried or concerned about treatment, you know, however much you dilute the treatment or make it easy, it's still those problems are still going to be there. And I think one of the other key things about, and I'm going to be really interested to see how the once weekly does in terms of adherence. All the indications are that it's going to be better for adherence, but we need the data. The one problem there is that if you miss a dose on a once weekly, you know, the effects are, you know, different to missing a dose on a daily. You know, the implications of that obviously, and it'll be interesting to hear Sherry's view on that. But one of the important things in getting adherence fluent, if you like, getting adherence to flow for people, is to create that habit, to get into that daily habit or weekly habit. And it does take longer to create a weekly habit than it does a daily habit, by definition. There are certain numbers, you know, they say it takes about 2 to 3 months to develop a habit properly, generally. And that broad criterion can be applied in the adherence world. So there's a sort of bit of a downside in terms of that long gap, prolonging the likelihood of habit formation. So it's complicated, but the factors are important and they are related. And I didn't really sort of go over those, but be interested to hear what Sherry says.
I will jump right in then. Thank you for the question, because I think this is an important issue. And when I give talks on the real day-to-day practical aspects of using long-acting growth hormone, we have very clear directives from all the companies what to do with a misinjection. How many days, if you miss an injection, should you allow to pass before you have to consider just simply missing it for that week? And how do you change the day of the week you're giving it? Because maybe there's a divorce that went on and now we have to pick a different day because it's going to be a day when the kid's going to be moving to another household. You know, there are a lot of these issues about long-acting growth hormone that really are going to impact on adherence, even of the more easily administratable long-acting products. So that's a very important question, but I think the companies are doing very well at providing schematics for patients and docs to look at to decide, okay, do they have to wait for the whole 9 yards if they want to keep the same injection day, or can they give it with a 2 or 3 day delay and it's not a big deal, and then still go back to the day that the parents had initially picked. I want to just say one other thing about the comment from the person that talked about SGA and Martin's plea to make sure you identify any syndromic causes of SGA. I'm thinking of floating harbor syndrome. And why am I thinking about this? Because one of the manifestations of this syndrome is CNS vascular events. And you will recall that Sage and our dear colleague in France demonstrated some cerebral vascular events in SGA kids treated with obviously a supraphysiologic dose. And I went back and I asked Jean-Claude, did you really check on the syndromic aspects of these SGA patients? And he said, well, it wasn't entered in the database. That's not a good enough answer. I think before we declare that we're going to throw the baby out with the bathwater, we really have to make sure that we as doctors have done the correct diagnostic workup specifically for this really mixed bag of SGA babies.
Yeah, thank you. Very good point. Thank you.
May I ask, John, so you know that there's quite a thrust in certain health systems about shared decision-making with people and about whether to intervene with an therapy or proceed with a operation, for example. Is there any evidence in the medicine adherence research of shared decision-making influencing medicine adherence? So, and I'm thinking of the situation of a family faced with a decision about whether to proceed with growth hormone, and the clinician presenting that problem to them as your child can have treatment, or the clinician frames that as your child is going to be offered treatment with a discussion about benefits, risks, alternatives, and the active decision of not doing anything, of not intervening.
There is a literature, and it broadly the literature shows that the more you can involve the patient or the parent in a shared decision about new treatment, the more likely it is they're certainly going to start the treatment. So that uptake phase is always improved. There's a sort of, they feel like they're bought into that decision. And that's a reasonably consistent literature. It gets very complicated though, in terms of long-term and impacts. There aren't that many studies looking at long-term outcomes, looking at, for example, persistence and discontinuation following those sorts of shared decision-making interventions, if you like. I think where it also gets complicated is that there are different, if one's thinking about someone being patient-centric, there are certainly groups of patients who don't particularly engage with the shared decision-making sort of model or approach. They would be well, you're the doctor, you tell me, and they may feel uncomfortable with that. They're decreasing in number now. I think, back 20, 30 years ago, that was often quite an uncomfortable position for some patients. So being put in that situation actually may not necessarily be helpful. I think with present-day healthcare, the more that one involves the patient, the more that one identifies any concerns or issues and explains the rationale and so on, all the evidence is the more one, the greater the likelihood is, certainly the person will start treatment. It looks like there's a greater likelihood they'll implement the treatment more effectively, but we don't know very much about long-term because there aren't that many long-term studies in terms of discontinuation.
Okay, thank you.
May I ask a question to Cyril?
Yeah.
Hi, Cyril.
Hi.
Did you have any chance to study the sleep architecture in children with growth hormone deficiency treated with long-acting? Because we have an experience with daily growth hormone and the GH, the sleep improve during the treatment. I would like to know if the lag may have some alteration.
Okay. Yeah, well, let me tell you that Canada was lucky because we were approached by all three companies. So Canada does have experience with all three products. I will say that Somatrogon is now being used. In Quebec, we have over 35 patients that are on Somatrogon. And I had 5 in the trial. They all have still stayed on, except the ones that now have hit final height, because we're talking a long time since that trial started up, right? The same is true for the patients with somapacitan. They're staying in the long-acting trial, but it's not yet approved in Canada. And for some reason, Ascendis decided not to take Lonapeg somatropin to Canada. So I can't talk to you about real-world experience since we don't have any more trials ongoing. I can tell you that there's another question in the chat, and I want to address it right now, and that is the fact that actually we're quite conservative in how we prescribe growth hormone in Canada for growth hormone deficient patients, and we use more of a European dose. We don't use the US dose or the dose in the trial. And because of that, I was very careful in watching my patients closely. I also, like most of my colleagues in Canada, tend to give growth hormone not too much to that gray zone growth hormone peak level of 7 and above. I really get it more for those under 8. And as a result, I did have some congenital hypopit patients in the trial, and they actually needed dose reductions. And we know that from daily. That's a no-brainer. We know that the more severe growth hormone deficient patients do well on a lower dose, and we often let the growth velocity and their achievement of their growth corridor to guide us in whether or not we need to continue to increase by body weight. The last thing I'm going to say is that I didn't mention the Japan phase 3 trial for Somatrogon, but they are also extremely conservative, and they actually started their trial by bumping up doses. They started with a much lower dose and then went to a mid-range and then the final dose. And they demonstrated efficacy just as easily by doing it that way. And I think it's a way of minimizing side effects. Does that answer all the questions? And in real life, what amazes me is how the patients wanted to stay on the long-acting and those on the daily wanted to switch to the long-acting. I think when you have retention in an open label extension, that's a pretty good indication, unless, I mean, there are factors that the doctor obviously may be controlling in terms of the reinforcement, in terms of the increased contact with the families. But by and large, I think patients are happy with the weekly injections.
Okay, well, thanks very much, Professor Deal. Thank you very much to the panel. I'm just going to now hand over to my co-chair, Professor Ross, for the closing remarks. Thank you, Richard.
Thank you very much, Justin. Well, I hope you have enjoyed this webinar and that it's achieved its learning objectives, particularly to help us understand how to investigate children with short stature, how to make the diagnosis of growth hormone deficiency, how to improve and support our patients with adherence, and particularly to understand the potential of long-acting growth hormones as therapy in growth hormone deficiency. I'd like to thank our 3 speakers who gave wonderful, clear presentations, and to thank my co-chair. But I particularly like to thank Flaminia Masproni, who has organized all this webinar through Medea, and has had fantastic communication with us, and I hope with you. And finally, of course, to thank you, the attendees, for giving up the time and making this such a great educational event. I think it's really fantastic that we had almost 200 attendees from 47 countries around the globe. Finally, when the webinar finishes, you will receive an email requesting that you complete a short survey. Please do that. And as soon as you've done that, you will receive your certification of attendance and your CME certificate. So once again, a big thank you. I hope you enjoy the rest of your day. And for those of you who watch the coronation tomorrow, I hope you enjoy that too. Thank you.
Thank you.